Okay. So I'm just going to share my screen now. Let me know if it doesn't come up properly. Here we go.
Perfect.
Excellent. Good. All right, so I'm sort of tying in with Liz's themes from Monday and talking, or just going through some cases really that presented to me with diseases that Liz talked about. So I don't want to give too much away, obviously, but the theme was endocrinopathies, and hypo and hypoadrenocorticism were the topics for conversation. So one of the cases that I wanted to talk to you about is, sorry, his name is Buster. Buster is a 10-year-old male-neutered cavoodle whose owner was the hardest person I've ever managed to squeeze a history out of in my life. But his presenting sign was exclusively nasal. He had a couple of background things like degenerative mitral valve disease, but he had this bilateral but predominantly left-sided nasal discharge, sneezing and reverse sneezing with a pretty acute onset for a 3-month history. He still had good airflow through both nostrils and no signs of congestion during sleep or overnight, which are all questions I ask owners, but he certainly seemed to have all his signs localizing to his nose. They're a little bit cost conscious, but they were very dedicated, and I agreed to do a kind of pared back pre-GA profile in just doing biochem and PCV-TVP, when normally a dog presenting with inflammatory disease like this, then I like to get a full profile done. So I looked at his blood tests when we first did them, and they looked really straightforward. The PCV was a little bit low on a manual read at 32%, but otherwise his biochem looked all normal, and we went ahead with a nasal CT and rhinoscopy and biopsies. And everything we saw was really consistent with just an inflammatory rhinitis, excuse me. But as I was discharging Buster, talking to the client, waiting for results to come back in, I'll have some news for you once the histo comes back. Mr. Corbett said, "What are we going to do about the diarrhea?" And I sort of thought, I've missed something here. He didn't mention the diarrhea at all that morning, but I just took the dog back out and ran a full profile just to see if there was any other hints on the rest of the blood tests as to what might be causing what turned out to be quite a chronic diarrhea, which had been progressing over the previous month. So we went ahead and did E8, which a lot of you are using in-house as well. Now the E8s are nice because they use a different technology than the Catalyst does. Is it called a Catalyst? Is that the one? The biochem machine? I think it is.
Yes.
Yeah. So the technology that this uses is vulnerable to less of the artifacts that the Catalyst is. So I usually trust these readings. So as long as the quality control's been done well, we can see here that Buster has a really mild metabolic acidosis. So his bicarb is just 0.1 below the normal range. His CO2 is also a little bit low. Now, most interestingly for Buster is that his sodium and chloride are both very low. So then moving on to the CBC, he had this borderline anemia, which we detected on our PCV. Now I'm going to quiz you, Amandine, if that's okay. When you see an anemia on blood tests, how do you go about classifying it?
So you want to define the severity of it and whether it's regenerative, non-regenerative, or pre-regenerative.
Right.
And then describe it using the red blood cell indices.
Good, excellent. Can you tell me what you're looking for from the red blood cell indices and which ones you like? So what does the MCV mean to you?
So the MCV is the mean corpuscular volume, so the size of the red blood cells traveling in the blood. And then the other one that's good is the MCHC, which is is it mean corpuscular hemoglobin content, I think?
Yeah. Exactly. So I think it's a concentration technically, but it doesn't make too much of a difference. So when we talk about the mean corpuscular volume, I usually just say mean cell volume just because it means the same thing and same letter. It's just easier. Sorry, I'm going to sneeze. Oh. So if the mean cell volume is low, then obviously we have small cells. If the volume is high, we have large cells. Now, there's not actually many diseases that cause a small cell anemia. The main one that we see is chronic hemorrhage that is external to the body. So hemorrhage anywhere along the gastrointestinal tract where the body can't reabsorb the components of the red cells is one of the more common causes of low cell volume. And the other cause we see really, really commonly is chronic inflammatory disease, so anemia of chronic disease. And then the hypo or hyperchromic, hyperchromic or hyperchromic refers to how much hemoglobin is in the cells. Now, there's not very many reasons why animals, in particular humans, get problems with iron storage where they get too much iron, they can get too much hemoglobin in cells, but there's not really much that causes hyperchromasia in dogs and cats. We are much more interested in hypochromasia. So if we're seeing hypochromic cells, it's usually because there's less iron in them. A little bit of a trick is that reticulocytes will read having a lower cell hemoglobin because they look paler, but it's just sort of the same amount of hemoglobin in a bigger cell, so it's just diluted, so the concentration per unit volume is lower. So if you've got a very high reticulocyte count and a low MCH, beg your pardon, then you've probably just got an artifact there. So the two differentials really I think of with this form of anemia, which is a low grade, so it's not a very profound anemia. We've got hypovolemia of the cells, so microcytic cells, and we've got a borderline hemoglobin, which I'm going to call probably normal, because we know that there's not much that causes hyperchromicity. So I'm going to call this a non-regenerative, because our reticulocyte count is less than 100, microcytic anemia. It could potentially be pre-regenerative. We don't know until we've done repeat blood tests over the course of a week and demonstrated that reticulocyte count hasn't gone up. So non or pre-regenerative microcytic non-regenerative. Okay, so moving down to looking at the white cells individually. Overall, Buster here has high white blood cell count, a leukocytosis, which looks like it is made up of predominantly neutrophils and lymphocytes and eosinophils, if we look at the percentages there. The red flags here for me are the neutrophil count is high normal, so it's nearly over the normal limit. Now, typically in a dog that has a robust neutrophil count, I would think it's not Addison's, basically. Normally dogs have a low-end normal neutrophil count if they're Addisonian or have a cortisol deficiency. Where I think we run into trouble using in-house blood test machines is, can we trust our neutrophil and lymphocyte count? And I think we've all been in a situation where we've had a dog with active inflammatory disease and they've got bands forming, and the in-house machines have counted them as lymphocytes or monocytes. So we've got changes in neutrophil anatomy and segmentation of the nuclei, and they're being counted incorrectly. And I have to say that because of the degree of neutrophilia, I discounted Buster's lymphocytosis as an artifact of in-house machine use. The one thing I couldn't really discount is that Buster has an eosinophilia. Now, any dog unwell should have a lymphopenia and an eosinopenia. So Buster presented with a very inflamed nose and very profound clinical signs. He should have had a lymphopenia, but I thought I had an artifact causing his lymphocytosis. The eosinophilia, I can't make an artifact. That's going to be a true finding. And that is one of my alarm bells to go chasing hypoadrenocorticism. Now, Buster had none of the classic presentations of being in a crisis, but the changes in his lymphocyte count and eosinophil count and this mild anemia accompanied by some vague gastrointestinal signs, raising this to the kind of the top end of my suspicion levels. Now, if you've got a lymphocyte count that you can trust, there's a good paper that came out fairly recently looking at what lymphocyte counts you should be sort of thinking, oh, that's definitely going to be Addison's, or it's definitely not Addison's. If you've got a lymphocyte count of less than 0.75, so if you've got a lymphopenia under 0.75, there is no patient with Addison's ever reported to have a lymphocyte count that low. So you can almost 100% of the time say this is not Addison's if the lymphocyte count is that low on a machine that you trust the count on. If you've got a lymphocyte count of greater than 5, that is 99% specific for Addison's. So here we're sitting at 5.38, but I'm not sure I can trust it. So I'd send that out to clarify for it as an external. If it's greater than 6, it's 100% specific for Addison's, according to this paper that came out. Now, the big caveat there is that's what the paper quoted, but we all know that dogs with lymphocytic leukemia can have a lymphocyte count greater than 6, and it's not Addison's lymphocytic leukemia. So there is an exception to that. But if your signs are consistent with Addison's, then I would certainly look at doing a stim test in any dog with a lymphocyte count over 5. So I think the probably biggest lesson for me in Buster was dogs with Addison's often have concurrent disease, and they might potentially still have a little bit of cortisol and a little bit of aldosterone in their system. But as soon as they're challenged with a concurrent disease, that increases their cortisol requirement. So we see all of a sudden dogs that didn't have clinical signs because they had just enough cortisol to get through their normal life, all of a sudden developing the clinical signs of Addison's when another disease comes up. So Buster's nasal findings did come back as allergic rhinitis. He had a lot of inflammation in his nasal cavity. And it was probably that tipped him into Addisonian symptoms and meant that he required treatment for the first time in his life. The other thing that was a little bit tricky about Buster is that he's quite old for developing Addison's. He's a 10-year-old dog, and typically we see Addison's between 1 and 7 years of age. It's a disease of adolescence, and it's more common in females than males. So he didn't tick a lot of the boxes to raise my suspicions early on. It would have been probably helpful to get a history of diarrhea, but otherwise. All right. So then I treated Buster for his Addison's and kind of deprioritized his nasal signs and just said, he's not going to die of those. Let's focus on the Addison's. I treated him with a combination of Cortate and Florinef. The cortisone acetate Cortate is my preferred option for treatment of Addison's because it's got some mineralocorticoid properties. Florinef also has some glucocorticoid properties, but when I'm starting out treatment, I'll always start on both. There's heaps of different treatments for Addison's. A lot of clinicians prefer using the DOCP long-acting mineralocorticoid injections. The reason I don't is because the owners have to give tablets every day anyway, and I feel like if they're giving 1 tablet, they might as well be giving 2 tablets, and I like being able to change the dose according to the results and then recheck again in a month rather than sort of have them coming in on day 25 and then day 27 and then day 30 after their DOCP injection to try and work out when they need their next injection. So I tend to prefer tablets, but it's totally clinician's preference. There's no right or wrong. So when I'm looking at how I'm going with my treatment, I look at florinef being the thing that causes changes in the electrolytes, and the cortate is the thing that causes changes in the CBC. So looking first at how I'm going with my florinef dose, what do you think about my numbers?
They look pretty good. The sodium's come up and the potassium's gone down a little bit, so they're within range.
I totally agree. Yeah. So if I think sodium is affected before potassium with Addison's, so I tend to look at the sodium more so than the potassium. So if I've got sodium in normal range, I'm pretty happy. If it's flirting with the low end of the range, just if it's sitting at 144 and my potassium's still upper end, then I'll probably look at upping it a little bit just to give me a little bit of a safety margin. But I'm pretty happy with how that looks. Ideally, I like to aim for around about a ratio of 30 or above, but 30 to 35-ish, but I certainly will eyeball these, like I call it between the flags, when they're between the high and low range. If they're sitting between the flags, I'm pretty happy with my florinef dose. More life-threatening is the cortisone dose. So cortisol is absolutely essential. I mean, a little bit of florinef will get you out of a crisis. It doesn't have to be really closely titrated, but cortisol will be life-threatening if we're not giving enough, because cortisol is required to maintain the vascular responsiveness to adrenaline and noradrenaline. So the vasculature can't have in absence of cortisol. So we end up with massive amounts of hypovolemia and hypotension, which will obviously lead to renal and end organ disease. So the abnormalities we had were this microcytic, hyperchromic, non-regenerative anemia originally, and that's responded beautifully in response to the cortate. So you can see here that the hematocrit is now sitting mid-range normal, which is excellent, and we don't have an excessive reticulocyte count at all. It's really similar to what it was. And our low MCV has corrected completely. So I'm quite happy with cortisol dose as far as the anemia goes. What do you think about my leukogram here?
So it's looking like there's definitely enough cortisol now, because there's the components of a stress leukogram. So with the neutrophilia and then the lymphocytes being on the lower end and the eosinophils on the lower end as well.
Good, yeah. Now this is the other trick with Buster. So typically I would aim to have the lymphocytes on the low end of normal. You're exactly right, but I would like to see the lymphocytes at the low end of normal in a well dog on cortate supplementation. In a sick dog, I think it probably should be below normal range, because that's appropriate for a dog that's still got raging rhinitis. So I felt like I'd probably underdone his cortisone just ever so slightly, but clinically he was doing brilliantly apart from his nose. So at this point, rather than up his cortisone, I elected to treat his rhinitis more aggressively to take away the level of physiologic stress he was experiencing. And that seemed to resolve things. We've got him pretty settled now on the same dose as we started him on, essentially. So that's Buster. He's a little bit of a tricky boy. Now I'll move on to Barney. I've selected all patients with names that start with B today. I just accidentally. Do you have any questions about Buster?
So if you're giving too much cortate, will you start seeing, you'd start seeing reticulocytosis and things like that, and that would tell you you're overdoing it, correct?
Not necessarily, actually. You give too much cortisone, you don't actually often get an increase in red cell production, which is a little it's kind of the opposite. Not enough cortisol means you don't get enough red cell production, but excess doesn't mean you get more. What I would typically see if I was doing too much is a lymphopenia in a well patient and a neutrophilia in a well patient. So that would, if I had a stress leukogram in a well patient, I would think I'm probably overdoing it. Underdoing it is the opposite. So if I've still got a lymphocyte count that's greater than 4, then I'm definitely underdoing my cortisol. Does that make sense?
Thank you.
It's definitely more the leukogram. And I think that's it's a good question, because most of the time when we sort of diagnose and start Addisonian dogs on like treatment, we send them back to their regular vets and we sort of schedule them for CBC and electrolyte monitoring. And it's often people leave off the CBC. So what we need to monitor is both mineralocorticoid and glucocorticoid supplementation, and you get no indication of how your levels of glucocorticoid supplementation are going with just electrolytes. So a lot of people prioritize that, but actually the cortisol supplementation is probably more important. The other thing with supplementing too much cortisone, you're going to get clinical signs of PUPD, panting, like Cushing's signs.
Yeah.
So a really accurate history taking in conjunction with this. So Buster didn't have any Cushing signs at this stage. He was so focused on trying to breathe through his nose and not put snot all over the house that he was showing no signs of Cushing's whatsoever. So the owners were quite happy with that side of things. But it's really important in, the next case I presented had quite bad, had quite bad cortisol excess signs. Certain breeds are more susceptible to excess cortisol. So we'll go through him and I'll talk a little bit about him as well. Alrighty, so Barney is an 8-year-old male neuter golden retriever who presented to the regular vet with quite an acute onset of lethargy, not wanting to eat, and he's a golden retriever. He was 40 kilos when he came in. This, for him to not be eating, was a really big deal. He had vomiting, lethargy, and anorexia over a 3-day period. He was really dull on examination, and he had sort of really thick skin and a borderline bradycardia. So his heart rate was around about 80, and he should have been quite stressed physiologically for how unwell he looked. His blood pressure was around about 80 systolic as well. So his heart should have been compensating for that by being tachycardic. So I was really worried about Barney when he presented. He came in with blood tests already done, and you can see his biochem here, and we'll work through this sort of one by one. So he's hypoglycemic. What are your differentials for hypoglycemia? Sorry.
Oh, there's a lot. Well, definitely Addison is one of them. An insulinoma. Anorexia, but again, in a 40-kilo dog, that would be really stretching it.
That's good.
Liver failure.
Good. Yeah, excellent. So I won't push you too far on your differentials for hypoglycemia, but I will bang on a little bit about why Addisonian dogs get hypoglycemia, because I guess it's sort of important in understanding what they're deficient in. Addisonian dogs are deficient in both mineralocorticoid and glucocorticoid. Mineralocorticoid shouldn't have any impact on glucose. So in Barney, based on the presence of hypoglycemia, we can say that he's deficient in cortisol. The reason is that cortisol is responsible for the breakdown of fats and proteins. It's a catabolic hormone. It breaks down fats and proteins, mobilizes them for use in stressful situations, but it also is responsible for hepatic gluconeogenesis. So cortisol causes the liver to produce glucose. So when we've got a deficiency, in cortisol, we get less hepatic gluconeogenesis and a resulting hypoglycemia. So Barney couldn't access his 40 kilos of supplies because he lost that ability, that cortisol, to drive that fat and protein breakdown. Does that make sense?
Yes.
Yes, good. Okay, next he has an azotemia. Why?
Because of the mineralocorticoid deficiency.
Excellent. Yeah. So it's probably a little bit of both deficiency, but predominantly when we've got an aldosterone deficiency, we can't hold on to sodium, and water follows sodium. So these dogs just get such profound medullary washout because the sodium and water are just running out of their kidneys. In addition to that, so mineralocorticoid definitely causes medullary washout and increased losses. In addition to that, I've got to get this right, there's so many double negatives in this sentence, but cortisol, oh my gosh, I'm going to have to check. So cortisol inhibits antidiuretic hormone release from the hypothalamus. So if you've got inhibition of ADH release, you're going to get diuresis. Too many double negatives. So we've got increased medullary washout, but we've also got decreased ability for ADH to work. If that makes sense.
Yeah.
So the other thing we've got is essentially circulatory collapse. So we've got cortisol is the blood vessels are absolutely dependent on cortisol to contract around a decreased blood volume. So the blood vessels' responsiveness to adrenaline and noradrenaline is really deficient when there's cortisol deficiency. So we've got decreased blood volume and then decreased compensation for that decreased blood volume, and therefore decreased renal blood delivery. So the kidneys cop it with Addison's. They really are kind of attacked from all fronts as far as their perfusion and their ability to retain fluid. And I think this is a really interesting point in Addison's and demonstrated well by Barney here. Barney has a low phosphorus, it's a phosphate. Why would Barney have a low phosphate?
Isn't it that phosphate also follows sodium out of the kidney?
It does. Yeah, exactly. So phosphate follows water. So you can say that you've got polyuria in Barney despite azotemia. So the creatinine is telling you that the GFR has dropped due to perfusion, but the phosphate has continued to go out. So you've got polyuria. So that just helps me to sort of differentiate whether he's got, essentially you could potentially get this early and acute kidney injury, which is another big differential with in a dog with azotemia. But most of the time with acute renal injury, you'll have an elevated phosphate and an elevated creatinine, whereas in these guys, sometimes you've got a low phosphate. The other enzyme that we have low, that we see quite commonly in patients that have been massively diuresed or polyuric, is the ALP, and that's sitting at 13 in Barney. So again, and cholesterol for that matter. We've got quite a lot of medullary washout in Barney. So I've kind of given it away. Barney is Addisonian as well. But I want you to look at what's missing on this blood test from your typical Addisonian presentation.
The electrolytes are pretty much normal.
They are. Yeah, exactly. This is a dog that's so unwell, and really he's not giving us very many hints as to why. So we've got some kidney involvement here. We've got a low glucose, a low ALP, a low cholesterol. Could there be liver problems going on as well? We know he's Addisonian now, but at the time we didn't. But he was so unwell that we couldn't raise a vein to collect blood. So he came over to the clinic with these blood results, but we had to do a cut down and put a central line in surgically to get venous access in him. He should, if he, vast majority of Addisonian dogs, if they're that severely affected, that severely deficient in hormones, they should have electrolytes all over the place. So Barney is just an interesting one in that he looks more like a cortisol deficiency with less of a component of aldosterone deficiency. Whereas looking at Buster, he had the neutrophilia and the electrolyte changes. So he had almost the opposite. He'll go back up. So he had that high neutrophil count and his electrolytes were all over the place originally. So I think Buster had more aldosterone deficiency relative to cortisol, and Barney has more cortisol deficiency relative to aldosterone. So then moving on to his electrolytes here, which we eventually got once we put a central line in, and he's even more normal in a crisis. So he'd had some fluid supplementation at this point, which had resulted in his potassium going back down really to low and normal. So I was really thrown by him. This is his CBC, and again we've got that same microcytic anemia present, which is non-regenerative, looking at the MCV and the reticulocyte count. Barney has a lot more of a typical low neutrophils, high lymphocyte count, and this is where it's tricky. We're seeing, can you see my mouse cursor actually? No? I've been pointing.
Yeah.
Oh, you can? Okay, awesome. So if we look at the lymphocyte count, he falls into that category of having a lymphocyte count of over 6. And essentially, as long as that's not bands being miscounted, we can say that almost 100% specificity, he's got Addison's or he's got leukemia. But given the other changes, we can almost say with certainty that he's got Addison's at this point. What he doesn't have is an eosinophilia, which is a little bit unusual. The fact that the eosinophils are within normal range in a very stressful situation is a bit of a giveaway that he's not got normal cortisol levels. Does that all make sense?
Yeah, how do you explain the monocytosis?
Can't really, but I think it's probably an artifact.
Okay.
Because monocytes and lymphocytes, activated lymphocytes, look quite like monocytes to the machine, we quite often see bands counted as either lymphocytes or monocytes. So I think it's probably an error. So it absolutely shouldn't be high, you're right. It should be low normal. All right. I think this will probably be our last one, but another B case. Benson. So we are changing theme a little bit here, so I don't want you to dive into these blood results assuming that this dog's got Addison's, just as a warning. So Benson is a 12-year-old male-neutered Cavalier who presented to the regular vet for coughing, and then after sort of having some workup for his cough, I think he might have got a couple of treats when he got home maybe, and developed pancreatitis. So he had an ultrasound and ultrasonographically confirmed pancreatitis. And his main problem is this kind of chronic cough over the course of 3 months or so, mostly in the morning or after a period of rest. Okay, so these are Benson's lab changes. So can you tell me what are the causes of elevated urea?
Decreased renal blood flow or decreased glomerular filtration rate, increased meat in the diet, so protein in the diet.
Yep. Is along that line, urea is often, sorry.
Yeah, if they have gastrointestinal disease and the bacteria in the colon produce more urea, is that right? No, they don't use it up as much. Oh, I can't remember.
Yeah. So gastrointestinal disease for sure. So if we've got gastrointestinal bleeding, processes that like a high protein meal. So it digests and absorbs the red blood cells and it causes an increase in urea. So basically I kind of try and break blood tests down into broad categories rather than like individual diagnoses. So I would say increased urea production or decreased excretion in this situation. So increased urea production, high protein meal, blood meal essentially. So if they've had a gastrointestinal bleed, we see increased urea. If we've got muscle catabolism, we'll also see increased urea. It's got to be quite a lot of muscle catabolism. And then obviously if the kidneys can't excrete it, it's the only way out really. So it builds up then. Now we do see urea building up with dehydration more than we see creatinine building up with dehydration. So I often look at the urea, if I'm looking at an azotemic patient, I look at the urea as a marker of their hydration more than a marker of their renal function, if that makes sense. Addisonian dogs, the urea goes up before the creatinine because the mechanism of their azotemia is dehydration essentially. So you'll see the urea is kind of considered the pre-renal component of it. Now why that's probably relevant is if you've got a dog in kidney failure and you've got a urea that's 50 plus, so over 50, and a creatinine that's 300, I'm going to be saying to the owners, I think we can make a big difference to this dog because there's a lot of pre-renal component or CAT. So I can rehydrate and the urea is going to come down and the creatinine is going to come down with it. Whereas if I've got a cat with a creatinine of 300 and a urea of 12, that cat's not very dehydrated at that time, and I'm probably not going to make a huge amount of difference to it. So that's sort of very unscientifically, urea creatinine ratio helps me to predict responsiveness to therapy of renal or of azotemia. Okay, in Benson, we do have an elevated phosphate, which same thing, same processes as urea. It could just be because he's had some gastrointestinal bleeding. He's got pancreatitis. He's got some gastrointestinal changes associated with that. It could also be because he's got decreased renal excretion of phosphate. So same differentials as urea, but again, I'm leaning more towards dehydration in him rather than true renal failure. I would need to get a USG to confirm that suspicion. So whether there's a primary renal problem rather than a dehydration. In Benson, and this is kind of what I want to focus on for him. Yeah, it is Benson. Sorry, too many B names. The ALT is very mildly elevated. So he's got gastrointestinal signs, he's got pancreatitis, and we've got an ALT of 174. The ALP, I would say, is getting to the moderately elevated ballpark at 376. Sorry, I'm getting this message again that somebody's logging into the Zoom account. I hope you can see me. Okay, so the ALT is mildly elevated, ALP is more elevated. So I think this is a really important point as far as how you interpret liver enzyme elevations, and that is what the ratio of ALP to ALT is. So typically with things like Cushing's disease, we'll see ALP being 2 to 4 times the ALT. If you're seeing an ALP that's 2000 and an ALT that's 200, then we're not just dealing with Cushing's. We're dealing with a primary cholestatic process. Now, the interesting thing about Benson is he's got 2 potential reasons for ALT and ALP elevations. So pancreatitis causes some local gastroenteritis, right? So particularly at the loops that run adjacent to the pancreas, we see some sort of secondary gastroenteritis developing. That changes the bacterial population in the bowel, it changes digestion, it changes the absorbed nutrients and toxins from the gastrointestinal into the portal circulation that is then going through the liver. So any dog with primary gastro signs or pancreatitis, so basically if they've got diarrhea, the ALT is allowed to go up to potentially 800, and we'll call that a reactive hepatopathy because it's dealing with a shift in digested nutrients and toxins. In Benson, we've also got this ALP elevation. So it does suggest that there's more than just a reactive process going on. So in those dogs with reactive hepatopathy, the ALP is usually normal. So we've got a little bit of a cholestatic pattern in Benson with the ALP being about double the ALT. His pancreas could be inflamed, could be causing a little bit of cholestasis that way as far as its interaction with the bile duct. What other value here would you look at to see how his biliary excretion is going, whether there could be an extrahepatic biliary obstruction?
The total bilirubin.
Excellent. What is it?
It's normal, sorry.
That's good, exactly. So it's very normal. So in Benson, I'm not really worried about, I sort of say there's a cholestatic problem. I don't think that there's any evidence of active inflammation in the gallbladder based on the blood tests we're seeing here. There could potentially be some sludging and stalling of flow, but it's certainly not causing bilirubin to back up into either the liver or circulation at this level, which is kind of what you expect. It's only a pretty mild elevation. So what I think is an important thing to have on your list of potential causes of ALP elevation is that every single patient with bronchomalacia or bronchial collapse has ALP elevation. So any patient that's presenting with coughing, whether bronchomalacia is primary or secondary, the bronchi get floppy when dogs are coughing. So even if they're coughing because they've got laryngeal paralysis or something like that, the bronchi eventually start to collapse secondary. You get bronchiectasis and stuff secondary to chronic cough. So you can expect to see ALP elevation with any chronically coughing dog, essentially, and not be too worried about looking into it as a primary thing. They don't know why before you ask.
Yeah, I was going to say, I'm like, did you say why? Did I miss it?
It's so frustrating. It's a very frustrating paper that was so enlightening because we see it in these dogs with profound flow collapse all the time, and we don't have a good reason for it because ultrasonography, the gallbladder is normal and things. But yeah, every single dog, and I think it might be just due to sort of not measurable increases in right-sided and therefore like vena cava pressures. Because of mild pulmonary hypertension, which is kind of beyond our ability to test for. But they don't essentially don't know why. There's a lot of speculation, but you can expect ALP elevation at that kind of level in coughing dogs for sure. We did an ultrasound in Benson, and he was like straightforward pancreatitis with no associated biliary obstruction or stasis, really. So I've really just discounted the ALP and would potentially check it once pancreatitis had resolved to make sure it had stayed stable and not climbed, and obviously resolving the cough. Now, what do you think about amylase and lipase as potential, opportunities to diagnose pancreatitis?
Ideally, they should be have a moderate to marked elevation to be considered a pancreatitis, because they will be mildly elevated with other conditions. So again, a decrease in GFR will lead to a mild elevation in both of those. And I think they come from other sources as well, where they can be increased in small amounts.
Yeah, absolutely right. Yep. So amylase and lipase, if they're normal, you can probably say it's unlikely to be pancreatitis. Probably. It's not 100%. But if they're abnormal, you can't say it's due to pancreatitis. Certainly gastrointestinal disease, renal disease, and a whole host of other sources of amylase and lipase will cause elevation. So not very specific, but quite sensitive test for pancreatitis. And we always do recommend backing up with either a specific pancreatic lipase test, or whether feline or canine, or an ultrasound or some form of imaging of the pancreas in a diagnosis of pancreatitis. Particularly in dogs and cats, it's a little bit more tricky. But that's pretty much all I wanted to cover for today. So we might leave it there and wrap up. Thank you very much for joining me, Amandine, and answering all my questions.
No, thank you so much. That was great.
All right, we'll I'll chat to you next week. Next rounds will be Monday with Alan, surgical rounds.
Oh, awesome.
Yeah.
Thanks so much, Anna. I'll see you later.
Bye.
Bye.